All right, guys, here we are. Thank you for attending the ad hoc meeting. It was really hard to schedule with the holidays and everybody that needed to be on the call. So I definitely appreciate the attendance, as well as this will be recorded as always and posted on our website. So I just really want to thank everyone. We've been working hard, and it's been kind of last minute stuff that's come together to where I'm in the communications to get out to you guys. So hoping when things um, um, hoping when things roll out and we have our procedures to follow with when the audits roll out through the pilot, then everything will be a lot smoother, and then I will be able to get the agendas out and get everything out in a timely manner. So I apologize to everyone, and I appreciate everybody hanging in there with us. So with that, with further ado, I'm going to move forward because we only have an hour. So the agenda is going to be the attendance. As I welcomed everybody, I wanted to give an update real quick about our RAC website. So the RAC website as of Friday has been updated in a section for the audits, the audit information. I highly recommend everybody go to the RAC website. I've also made some changes to where in the section where we get feedback, comments, ideas, it is now directly emailed to me because it was getting put in a place of nowhere, and I couldn't find where the past, I think it was the past 20 days, if anybody put anything in there. So please go back into the comments and suggestions and feedback, and it will come directly to me. And then as far as the attendance, actually, I can get a printout of the attendance. So with that, we can just continue forward. I sent in an email to all the board members what there needs to be a vote on. And I don't know if everybody necessarily has to vote on record here per se, because this is kind of more of a committee, the provider advisory board. However, I do need it in writing from everyone in an email, whether they agree with the section of the Senate bill that says it's 3.3 C3E, and it says provide preliminary RAC audit findings to a provider within a reasonable period following receipt of any requested medical records as determined by the State Department in collaboration with the provider advisory group created in subsection 3.5C. I think that's one, my eyes are terrible, of this section. So in a nutshell, the department and the contractor have a recommendation of this being 60 days of based on extensive conversations. It's also the 60 days is consistent with the federal customer service standards. So I want to open that up for anyone if they find that 60 days is reasonable, not reasonable, any suggestions, an I do, an I know, anything would be helpful.
You know, my only comment on that
Uh-huh.
is 60 days is really determined by the volume that's sent. If they send 100 reviews and say you got, I guess if they send 100 reviews every month and they say you have 60 days, you can get backed up pretty fast. So I guess that would be my only comment. So I don't know. I don't know what I don't know, but as it is right now, I would say 60 days is reasonable, but I never know.
Right.
No, so Dr. Brown, I want to make one clarification if I may.
Sure.
This is actually 60 days for our vendor.
Oh.
To get back to you.
Oh, I like that.
You have submitted your medical records.
Yeah, I like that.
We thought you probably
I'm sorry. I thought it was for us. And I'm like, I never know because I can never figure out what's going to happen because it's like you'll go 6 months and get nothing. And then all of a sudden you'll get a whole bunch.
No, so this is codifying that. So once you get your, once you submit your medical records, Once they have your medical records, this is how much time they would have to get back to you with a
Yeah.
notice of preliminary
I
findings.
like that. That means that they're not sitting in limbo for 6 months or longer waiting for everything. I like it. Okay, so do you want to resend that email to us and we
Yes.
can respond to it? That
Sure.
way we
After
have it
this,
right
I
on the
will just,
top.
yep, Derek, I'll just send a clean email out to all the board members, and they can just send
Yeah.
back whether they agree,
Yep.
disagree, and then we can just go from there.
Yep, that would be great. I will happily agree.
I don't think anybody will disagree, but I wanted to, put that
Yep.
out there so that everybody can, give you guys say of it. So
Okay.
yes, I will send a clean
Thank you
email.
for clarifying that for me.
Thank you, Stephanie, for the clarification.
Yes. Yes, she got me off my ledge real fast.
I'm just going to walk you back.
Yep.
Sorry
Thank you.
about that.
It's okay. Because I
Okay.
can't remember everything that's been sent to me.
What? You can't keep track of all that stuff you get?
Oh, heck no. I have, you know what? I typically have to do stuff in real time. Otherwise, it gets lost. You'd hate to know how many emails I get in a day.
Oh, I hear you there. Okay.
Well, we appreciate you all taking this one. So
Yes,
Yep.
thank you.
Yep.
So I'm going to turn this over to HMS, where they're going to present two case scenario summaries that we have. The first one is going to be the FFS paid same day as encounter, and that is going to be by Matt with HMS.
Hey.
Hey, Matt.
Right. Okay. Let's see if I can. This is very small on my screen. I don't know if it's small on everybody's screen or.
It is small. Let's see. It's in.
I mean, I can read it if I get nice and close, but I don't know if everybody else can. What was that?
It's perfect on my screen.
Okay, perfect. Okay, so this concept is it's an automated review scenario. What we're doing is we're identifying essentially duplicate claims, one being paid by fee-for-service Medicaid, the other being paid by one of the managed care entities. We're matching on the date of service, the patient, the provider, and identifying those instances where a claim was paid by a managed care entity, and then it was also for some reason paid by fee-for-service as well. The assumption that we're making is that the individual is or was enrolled in that managed care entity, and that payment is the one that should have been made, and then the fee-for-service payment is then the overpayment, and should be recovered on. We've done there's a decent amount of exclusions in this particular scenario, and those especially the behavioral health services. There's a extensive list of diagnosis codes that are being excluded because those services fall under or could or should be paid under the RAEs. So this particular scenario is only focused on those services that are not that are covered by the managed care entities, and should be paid by those entities and not fee for service. We also exclude claims that are so claims not provided. Obviously, claims not provided by MCEs would be excluded. We wouldn't be seeing any overlap between the MCE and and fee for service in those scenarios. So dental care, home and community based services, hospice services, long-term care, stuff like that, that shouldn't be provided by the MC. Those services are excluded from this scenario. And I think that's really most of the main logic. I'll pause there and take any questions that you have initially here.
I don't have any questions. That makes sense.
Okay. And I think I said that if I didn't say this is being run across all claim types. So it is looking at inpatient, outpatient, and professional claims. And is there any other questions or anything else I can clarify?
Matt, this is Shauna with Denver Health, and I just have a quick question, and I'm not going to pretend like I know all the rules off the top of my head, but I know that there's sometimes special situations where certain services are carved out and maybe fee for service covers a certain item, even if a patient's covered under a managed care. So maybe there's a situation where, you know, they're under the managed care and the majority of services are covered by the managed care, but a particular item has to be carved out and billed to fee for service. I'm thinking like in the terms of like a LARC carve out, but obviously that's not one that meets this criteria. And like I said, I'm not going to pretend like I know all the rules specific to Medicaid because there's so many, but I'm assuming that there's going to be some kind of consideration like that for some of those type of carve out rules that I'm sure there's something that would fit this bill. I can't think of one off the top of my head, but have those kind of situations been considered and put into this criteria to make sure that those items are not brought into the scenario to be considered, making us then have to look at them and go, oh, wait, this was properly billed because it meets X situation.
Yes, absolutely. So we've removed anything that that would be one of those like carve out type situations. We have removed all of those from the concept.
Okay. Like I said, I can't even think of one off the top of my head. I'm just thinking of all the years of reading bulletin articles and things that come into mind. I'd have to go back and refresh on some of those rules to kind of come across one.
So like dental, home and community based services, hospice services, long term care. All of those are services that are carved out of this concept. And then there's some additional, more granular exclusions that we also put into the logic of the query based on those types of policy exclusions.
Okay.
Anything else?
Any other questions or comments?
Not for me.
All right, I think for Matt.
All right.
All right, I think it's safe then that Kelly will move on to the DRG, please.
Hi, good afternoon, everyone. I'm Mary Stein. I'm the Senior Director for Clinical Policy and Quality here at HMS. And also on the call with me is Kelly Dixon, who's our Coding and Clinical Specialist, and Dr. Johnson, who's our Medical Director. So for today, I'm going to run through the DRG validation scenario. It's a complex scenario. And then I'll run through the document provided, and then we'll open up for questions afterwards. And hopefully Dr. Johnson or Kelly can jump in to help with any questions that I'm not able to answer. So for DRG validation, HCPUF and HMS will request medical records from providers to conduct a post-payment review of acute inpatient hospital DRG paid claims. The review is to ensure hospitals are reimbursed accurately by verifying proper coding of all diagnoses and procedure codes, and accurate and complete recording of data elements that affect the DRG assignment as documented in the medical record. For DRG review, we'll review claims to verify that all diagnosis and procedure codes are billed according to the ICD-10 official guidelines for coding and reporting, as well as coding clinics, and that the codes are consistent with the documentation in the medical record, resulting in accurate DRG assignment and reimbursement. The medical records will be reviewed with the codes validated from both a coding and a clinical perspective, and HMS does apply coding guidelines in effect at the time the services were provided. A little bit more about coding and clinical validation. Coding validation will verify the codes are billed in sequence in accordance with those official coding guidelines. And clinical validation verifies that the diagnoses coded are present in the medical record based on the clinical documentation, and the results of related diagnostic testing were consistent with those diagnoses. There are 5 key elements that we verify as part of our DRG validation review, and it's really our review focus. So as part of the review, we'll be verifying that all diagnosis codes billed on the claim were coded accurately and are supported by the medical record. We'll verify that procedure codes, again, were coded accurately and are supported by the medical record. We'll also verify discharge status codes and all other data elements that affect the DRG assignment and reimbursement are again coded accurately. We'll verify hospital-acquired conditions were coded with the appropriate present on admission indicator, resulting in accurate DRG assignment and reimbursement. And lastly, we'll validate the clinical documentation and the results of diagnostic testing to ensure they support the billed diagnoses. From a guideline perspective, HMS utilizes the ICD-10 CM official guidelines for coding and reporting and coding clinics, as well as industry standard criteria and definitions to substantiate the billed diagnoses codes that affect the DRG. For clinical validation, the diagnoses documented in the medical record are substantiated by criteria that are accepted by the medical community. The criteria typically come from professional guidelines and other evidence-based sources. We included an example here. So for example, when utilizing the ICD-10 code for acute kidney injury, the 2016 Kidney Disease Improving Global Outcomes, KDIGO, conference definition will be utilized. With this, the diagnosis of acute kidney injury is based on the individual patient's normal baseline creatinine rather than the lab test reference ranges. You might want to, can you scroll down a little bit in the document? Sorry, I have a larger version on my side so I can see a little better. Okay. So we did include some additional examples of references and guidelines that are used as part of the DRG validation review process. This is not an all-inclusive list. We just wanted to provide some high-level examples. So here we included the ICD-10 CM official guidelines for coding and reporting section 2, which is selection of principal diagnosis, section 2C, which is 2 or more diagnoses that equally meet the definition of a principal diagnosis. We included section 3, which is reporting additional diagnoses. And then we provided some examples of relevant coding clinics. So AHA coding clinic from Q3 of 2017 for severe malnutrition, and then coding clinics from Q4 of 2018 and 2019 for body mass index. And the last couple examples we provided, one is the Improving Global Outcomes for Acute Kidney Injury work group that we already discussed above. And then also the third international consensus definition for sepsis and septic shock, which is also known as sepsis 3.
You know what? I disagree with this. Just so you know, because sepsis 3 has still not been accepted everywhere and it's not accepted by CMS. So and it also doesn't fit into ICD-10. ICD-10 has 3 different sepsis codes. Okay. The third consensus for sepsis has 2. So it doesn't match up.
So, yep, thank you for that feedback. Kelly,
And the other thing is that the one for malnutrition, that uses Aspen criteria. There's GLIM criteria also.
Yes,
So
there is
people use different things. And, you know, for coding validation, the attending physician who sees the patient, their opinion is supposed to have some weight on this, and they can use various criteria.
Yeah,
So-
this is a real hotbed.
Oh, I know
And-
it's a hotbed. It's a
and-
hotbed
and-
for everybody.
Yeah, and the hard part is we have to have some place to start. And the Aspen versus the GLIM, the intent is actually to use the GLIM. Because Aspen joined GLIM in like 2018 or something like that.
I would say, but the coding clinic in 2017 is Aspen. I'm pretty sure.
Okay, yeah, and you
But
may
still.
be right. You may be right. So this is where I don't know how to fix this. I'll just be honest with you.
Well, you and me both. I think they need to fix it by taking simple sepsis off of a MCC.
So
it doesn't code as high.
Yeah.
But I think I think ICD 1011 is going to fix it.
Yeah. So what the intent here is, the bottom line is we have to have some starting place with the guidelines, and we've got to also take into account circumstances. You know, one of the things that comes up is with AKI that the creatinine, and I don't remember the exact, I think it's over 3 or it's 3 times the previous value. Well, sometimes the providers don't know what the previous value was.
Right.
And so the intent is to start out with this and look. The sepsis 3, yeah, that one is just a nightmare. You know,
That's a nationwide issue.
Exactly. Again, I think that there are issues with using sepsis 2 because, you know, I tell people I can run up and down the stairs and make my heart rate go up and, you know, my respiratory rate go up.
Yep, I know. And if you have a hangnail, you have sepsis.
Yeah.
I agree with that. I mean, there's common sense involved.
Right. So just so you know, my intent, and it's going to be difficult, is before we even send out notice of preliminary findings in conjunction with HMS, to review at the very least a big sample of cases in some of these controversial things. And our discussions with HMS is to say, you know what, we've got to use some common sense clinical. And again, that's difficult because I always tell people I had 2 other providers and I could present a case to them, and between the 3 of us, we had 3 different opinions. So we're not going to come to a complete consensus. You know, it's just reality. You know, I've had some discussions with Intermountain Health. We've talked about children's, how you apply pediatrics. So I think that the bottom line is we have to make some type of a guideline as our base, and then say from there, how do we, you know, interpret this moving forward using some common sense? Do I think it's going to be perfect? No. But again, everybody's going to disagree. And I don't know so I guess I'll ask the question for sepsis. What would you use?
You know, I can tell you that we use the sepsis 2 because that's what CMS does. And CMS is kind of an immovable object. But to go along with that, we don't take a single reading. You have to have sustained readings, you know, of tachycardia and tachypnea. Otherwise, I don't count those. And they can't be explained with any other reason. Like if they have pneumonia and then they're tachypnic, I don't use that.
Yeah.
And if they have AFib and they're tachycardic, I don't use that.
Yeah.
So we have to apply common sense to this to where it is truly something that's abnormal.
Yeah. And I just, and again, we could go around and around about this. I've heard people say CMS accepts sepsis 2. Well, they use sepsis 2 for their quality metrics and their early screening, but I've not found anything that says this is what our definition of sepsis is. For the sepsis quality programs, you're absolutely right. They use sepsis 2. I just, it's really difficult.
Well, we have education we got from Noridian on that.
Uh-huh.
And they used sepsis 2.
For
For
Medicare?
the diagnosis, yes.
Okay. And that's where it gets complicated too. Medicare is a different animal than Medicaid, which is a different animal than Aetna or so what would you suggest?
I wish I had a great one for you. I mean, I mean, obviously that it has to be applied into where it's sepsis is a sick patient.
Yeah.
I don't know, and we have people that never meet sepsis 3 until the very end when they're literally coding.
Right.
So, I mean, the purpose of that was to be more inclusive rather than less inclusive.
Sure.
To get people into those bundles.
Encourage early treatment. Yep. The sepsis bundles. But when you get to a final code, I guess that's where I really struggle.
I think that, I mean, first of all, anyone that's been in the hospital for 2 days or less probably was never septic unless they died.
Right.
So, I mean, I whenever I see those, I'm like, yep, you're right. That person was not septic. And when you see someone with persistent, fever and tachycardia and other things, first of all, the other thing is that I usually don't use fever and tachycardia on their own. I always look for something abnormal with the white count or their temperature. I want something else that can't be explained with I just stood them up and sat them down and everything else.
Yeah.
So but I still do use it. And the other thing is that sepsis 3 isn't great either, because people with chronic disease, all their stuff gets thrown off.
But it's supposed to be changes.
It's supposed to be a new. Yeah, I know.
Yeah.
That's tough because they decompensate really easy.
Yeah.
Can I throw out a thought here?
Sure.
Because I absolutely hear what you're saying, and I'm guessing that there's other folks on the line from other facilities that are probably thinking the same thing, although you might be our only physician.
I might be.
And so,
I do a lot of these reviews, and I just know kind of how the denials come in and how things get approved. And so
I'd like to
we're very selective on what we appeal in this area. But
because of our new processes with, both the exit conference and the informal reconsideration, and the fact that we're not actually sending you a notice of action till quite farther down in the process, I would really like to see what we actually shake out with this.
Okay.
And where it lands, if it ends up being, wow, we're just, to Dr. Jeff's point, we're just seeing so many of these where, you know what, we agree, this should be overturned. Or if we're starting to see where, as you're saying, it makes sense that this probably shouldn't be sepsis, probably shouldn't be coded as that. I think I would like for us to experiment with this a little bit.
That's fine.
If y'all are willing to do that through that process, right, to help us kind of learn and to help us gauge.
Right.
Because to Dr. Jeff's point, we have to start somewhere.
Yeah, I know.
And it would be helpful to see that.
For this right here, I think the real answer is somewhere in the middle.
Probably, yeah. But I think it would just be helpful to let it play out and let's see. I mean, like I said, we can always agree in an exit conference. Yeah, you know what? We'll give you that one. We can totally see where that makes sense.
Okay.
So, Dr. Braun, so you understand too, our intent is to send out the first round a very limited number of medical record requests. We're not going to just roll the whole thing out.
Yeah.
So I guess from that standpoint, I guess I'd like to do what Stephanie's saying and see what we're coming up with. And
okay.
Dr. Johnson, I think you're on the phone, aren't you? Or on the call also?
Yes, I'm here.
What suggestions, thoughts? You've dealt with this in numerous states.
Yeah, you know that Dr. Braun brings up some interesting points, but the point that is consistently not mentioned is every organization who has embraced sepsis 2 has embraced sepsis 3. Now, when I say institution, I'm not talking about hospitals. I'm talking about nationally organized institutions. And I encourage you all, if you haven't, to go to the organizations that have embraced sepsis 3.
Mm-hmm.
So this has been going on since 2016. And the rest of the arguments that have been made are correct. And that CMS uses sepsis 3 for quality, or sepsis 2 for quality indicator. And that is where it is set. Almost all commercial insurance company uses sepsis 3. And I think where you all have come to with regards to, let's use sepsis 3, see where it ends up on a sample of cases. And I know it's going to show up because of the way it impacts the DRG. We're going to see cases that are going to show up right away. And a discussion can be made at that point in time with regards to whether you all want to proceed forward with that criteria or not.
Okay.
Is that workable? And I thought did somebody else have their, I can't figure out how to raise my hand in Zoom, sorry.
Same here, Stephanie. Thank you. I was just curious, rather than proceeding and seeing how things shake out, I'm wondering if we can go through an exercise of a couple of blinded examples so that we get a sense of how HMS is evaluating these accounts through the audit process, specifically for sepsis. Because what concerns me as a non-clinician is that we're being asked to bend or to modify processes to accommodate different payers. So, I mean, and in reality, it's the documentation that concerns me the most. I would like to know from HMS specifically, what are you looking for in that medical record that is either there or not there? And if we had a better sense of how you're evaluating that, then I would be better positioned to say, yep, I agree with this, we should move on. But going into it, knowing that it's a hotbed, knowing that different payers assess sepsis differently, it just perpetuates the problem. I mean, we're not on the same page.
Yeah, I totally hear you, Katie. And HMS folks, you jump in and tell me if I'm wrong here. Part of the reason why we want to, what we've been euphemistically calling slow roll, out relaunching this is because we are trying to learn from it. And so that's why we want to do a very small number of these claims so you can actually see that and see what the criteria is and see what the outcomes are. And then we have a chance to talk about that.
So will there
I don't know how to do I wouldn't know how to do a sort of a blind study, without actually being able to see, here's some real examples and here's how we ran them through the criteria. Now let's just sit down and talk through them.
So say we have 5 accounts, sepsis accounts that get pulled for audit, and we request to engage in that discussion. Is there going to be a clinician on the call?
That is Dr. Jeff.
Yeah, I'm sorry, I was trying to unmute myself. No, that's my
He is the short
intent.
straw for us. He will be in all of those conversations.
Yeah, and it will be, the discussion will actually even occur before the notice of preliminary findings go out, letters go out. And like I say, I've spent a lot of time on this, and the more time I spend, the more confused I get, because it is just, the like I say, the rules, depending on who you look at and what you look at, it's not clear. And that's where I think we've got to come to say, here's going to be our starting point. sepsis 3, but we need to look at this and say, would a reasonable person, and I, for example, Dr. Braun brought up a good point, somebody that's in the hospital less than 48 hours. And then you're going to have somebody come along and say, well, they met the criteria. Yeah, they were only in for 48 hours. And I somehow we have to come up with some objective starting point and then go from there. And I honestly don't know exactly what's going to be perfect. And that's why I think that starting out with some cases and looking at them and having a discussion will be the case. And that was a very long answer to a short question. The bottom line is I will be intimately involved from the start.
One example that you all might be familiar with is someone comes in with elevated liver function tests and elevated bilirubin and doesn't have a viral etiology that we can document will qualify for sepsis. They go home in 2 days, and I think that brings up Dr. Chapman's exact point. Like, well, did that patient actually have sepsis or not, or was it a non-typable viral illness that created the liver function test?
But, I agree with that. And the ones that never really have a source identified, those are very difficult to ultimately call a sepsis too, because they could have non-infectious SIRS. So there's a lot of stuff that happens in there. But then again, you get some of these people that never have organ dysfunction and come in with, sick as can be and have positive blood cultures, and using sepsis 3 never meet the criteria, and they may be in the hospital for 5 or 6 or 7 days. So it requires the person who reviews the chart to use their brain and say, this person was sick, that was sepsis, as opposed to this person came in with a cold or bronchitis, and they really did not have sepsis. They did not have anything that was distant. They had nothing else going on, and look how fast they recovered. So, I think that's the key to the way we review these.
Yeah.
Is that it has to be reviewed with a brain, not just looking at the criteria blindly, but using your brain. So I don't know a better way to put it, but.
And I agree. And I think that's what, the intent is. And I'm sure the HMS people will tell you, I kind of came into this late and I saw some, reviewed some cases, and there were a number of cases that originally the HMS reviewers, said this is an overpayment. And then Dr. Johnson or someone else looked at them and said, no, I think this is okay. And we've just made it clear that we want to, a tie goes to the runner is what Ralph uses.
That's fine.
Yeah.
Okay.
Yeah, Dr. Brian, our big brain that we hired is Dr. Jeff. And that's why we're making him available to you all for this process.
Oh, I know.
And if I'm considered a big brain, we're in trouble.
That's okay. We'll share one.
But this is great. This is actually super helpful. And I really appreciate this dialogue, because this is exactly how we want to tackle some of these sticky issues, right? I mean, the fact of the matter is, it's an art more than a science as medicine, as you all well know. But there has to be a place for us to start. So I appreciate you all being willing to kind of say, let's start this real slow. Let's look at, a very small number of actual cases, and let's really talk through them using those big brains and using that common sense to say, let's find the right level here of what we want to look at, and going forward, help us calibrate to that right space, right? But I don't think we can do that without having those conversations.
So I think one of the other things in my working with HMS, and just so everybody understands, HMS has been working really hard because Colorado is a different animal than a lot of places. And so some of it is this resource utilization. I mean, like you say, if you've got somebody that never hits the SEP3 criteria, but they're in the hospital for 8 days, and it's clear that a lot of resources have been used, that's going to go into the equation too. It isn't just what the numbers are. And vice versa. If someone is in the hospital, they're in the ER, and that's the other hard one the other way is if you use SEP2, they don't come in the ER, they're a little tachycardic, maybe even a little hypotensive, and you give them a liter of fluid and all of a sudden they're fine. Is that, sepsis with, septicemic or septic shock? I don't know, very hard. So.
Mhm.
I
Okay.
will- If you guys are okay with it, I will jump back in. That's a lot of great discussion. And it leads into the last couple of topics in the document. So I will not read verbatim, but I'll just cover them really quickly. The first one is our clinical staff performing the reviews. To your point, it's not just checking a box. We've got to make sure that we're looking at the whole picture and we're using appropriately trained, skilled clinicians and coders to perform that medical record review. So our team includes registered nurses and certified coders, as well as physicians that do have that additional training in billing and coding guidelines, as well as Colorado rules. Our physician team have active unrestricted US medical licenses and are board certified in appropriate medical specialties. And again, are familiar with Colorado laws and community practice standards. And then the last point of this brief to cover really quickly is that HCPF and HMS will, as we identify ERG claims that are potentially billed incorrectly, we will really work together and collaboratively to ensure those are thoroughly reviewed, that the needed discussions are had. The claims are considered only potential overpayments and may be subject to recovery, but prior to issuing any notices of preliminary findings, HCPF RAC medical director and coding staff will be involved in the preliminary finding review process. And the remainder of the document just talks about references, so I'll pause there.
I think the other additional little piece that isn't in this, and Stephanie and I were just talking about this morning. In the past, there had been maybe a bulletin that went out with billing that wasn't taken into account, and we've really upped our effort to be sure that we are including all those things in the criteria that are used. So if there was a bulletin that said, yeah, sepsis, use sepsis 2 that went out 4 years ago or something like that, we're trying to be sure that we're taking those into account, because you're doing what you should do from a provider side. If there was a bulletin that said, use this coding sequence or use this whatever in the past from the department, we need to honor that.
Two
Go ahead.
comments I would
Go
like
ahead,
to
Dr. Braun, or Dr. Johnson.
make is one, a common argument that we hear is, well, the coding clinic says this and the coding guidelines say this. The coding guidelines supersede the coding clinic. And that's stated by ICD-10. Any questions with regards to that? The second comment that I would like to make, and it's a common concern, I think, with regards to the hospital providers, is they say, well, we're allowed to code this. But yet it didn't take any clinical resources during the hospital stay to treat that particular diagnosis, and we'll remove it. So that is what we look at for clinical validation and removal of code. Any questions with regards to that?
So,
Sure, Dr. Young.
yeah, I just want to make sure that I'm clear on that one, okay? When you have patients that come in with things like heart failure and some other things, those conditions typically do play, a part as far as how you treat their other conditions that they come in with. So it does increase the complexity of the patient. So I think that, if you say, well, I didn't really treat it, but it's still being considered. So even like diabetes and some other things, I mean, those are all considered. So I don't know where that puts us. I mean, I understand, like, if you say that, well, they had hyponatremia because their sodium was 133, but I didn't do anything. Yeah, that one should probably be removed. But there's some others where I think that there's, even though they were not quote treated, they just were kept on their normal routine medicine or whatever. It still influences their care.
And I understand where you're coming from on that particular issue. A common scenario that I use is someone who has a dysplastic nevus. So they have this dysplastic nevus, and it's documented by the primary care physician. It's on their face. It's very obvious, and it's coded. Well, it was never treated during the hospital stay. So hopefully that makes it black and white. Now, I know they're not always going to be that black and white, but.
Okay. Well, there again, I think it's another one where we'll see how it's, how the rubber hits the road on these ones here and how it's actually used. I mean, in theory, I don't disagree with this.
No, I think we're going to end up, like you said, Dr. Braun, probably somewhere in the middle, right?
Yeah, that's fine.
Figuring out where that calibration makes the most
Yeah.
sense. So I have two questions for you all. And Megan, I should ask you first. Is there anything else on the agenda?
Yes.
Oh, okay. Then I will ask these two questions really fast. Sorry. Sorry, what was it, Megan?
It's not anything, just some updates and stuff.
Oh, okay.
Yeah.
Then I'll ask these two questions really fast. Does anybody have any more questions or concerns or discussions about this particular scenario? And if yes, please do not hesitate to outreach me, Dr. Jeff, anyone of us on the team. We're happy to schedule time to talk with you or other folks from your teams if you need. Second question though is more sort of procedural. We've been through a few of these now, and I just want to get a sense from you all. Is this process and the structure of reviewing these audit scenarios in this way, is that helpful for you all? Does it make sense? Is there anything that you feel like is missing from that process or that structure that you would like to see? I just kind of want to get a sense, are we hitting the mark in being able to bring this information to you in a way that makes sense to you, in a way that's helpful to have these kinds of discussions?
I think it is.
Other folks, is there anything that we're missing that would be helpful for you? Awesome. Well, I appreciate that. And again, if you have suggestions or you have ideas, please don't hesitate to let us know, and to outreach us and just say, hey, I would really love to see this. But we're trying to make sure that we can get these things down in a way that make these meetings productive, help us have good conversations like we've been having. So I really appreciate that you all have been so patient with us as we've been sort of rebuilding this ship. So thank you for that. All right, Megan, I'll stop talking and give it back to you.
Thanks, Stephanie. Okay, so I think if we can have the agenda back up, Kelly, please. I know on the agenda, aside from this ad hoc meeting, the next provider advisory board meeting is December 11th. Everybody can go, or anybody listening in can go online. It's public, and register for that. You all will be receiving from me on the board, probably a Google form by the end of this week, to come up with dates for 2026 meetings. It's that time already. So that'll come out, as well as an email. The email will come today about the Senate bill verbiage. And then the only other thing is, I just want to stress, and maybe the people on the board can stress in the community, to the provider community, really, if everybody can go in and register in the HMS portal and review all of their information, whether it's current and updated, if it's not current, because we are going to, start audits again. So we start the pilot with the letters, I believe, are going out this week to the pilot providers that Dr. Jeff and I will be working closely with on the other two scenarios that the board had. The professional duplicates and the the NEMT trips without medical documentation, with no medical documentation. So those will be rolling out this week. So I know that actually we have people on the board who are in that pilot. So Dr. Jeff and I are your people for this, and we will be working with you closely. And then another thing that I wanted to stress too to the provider community, and maybe you guys can help pass this along, is that interchange through Gainwell is separate than the HMS portals. But there's a lot of issues with the information not being up to date and current in interchange as well. And if you could potentially help us out by communicating that, we communicate it in the from the department level. However, word of mouth is always the best. And we just need the most current, up-to-date information so that we can communicate with you all. With that being said, I don't have anything else other than I mentioned the website that we're going to have, lots of changes. HMS is working on their website closely with us to mirror. So there's a lot of things in the next 6 months that you guys will see that we've been talking about that are coming together. Other than that, I don't have any other updates unless you do, Stephanie or Dr. Jeff.
Other than an HMS, you can correct me if I'm wrong, but if you're already registered in the portal, you don't have to re-register. It's just we want to be sure the information is correct and up to date.
Yeah, thank you, everyone.
All right, with that being said, I guess no questions, and I will give you guys back 15 minutes, 10 minutes of your time. And I appreciate everybody coming today, and have a great week.
And happy Thanksgiving to everyone.
Thank you. Happy Thanksgiving.
Bye.
Bye, everyone.